Good morning, everyone, and thank you for joining our international rounds. And today, it's my great pleasure to present Alex, who is how we know him, is Dr. Van der Bruaene. Sorry, Alex, if I pronounce your name wrongly. And Alex works in Leuven, and one of his areas of expertise, among many others, is the Fontan circulation. And he's going to talk today about if there is any role for pulmonary vasodilators in patients with Fontan circulation. A big topic. I'm sure he will shed a lot of light in this interesting topic. So Alex, the floor is yours, and looking forward to your talk.
Thank you, Rafa, for the kind introduction. Hello, everyone joining this rounds. I must say that the topic is a difficult one, but it's one I'm quite passionate about. So is there any role for pulmonary vasodilator therapy in patients with a Fontan circulation? So as Rafa indicated, I work in Leuven. This is our hospital, so it looks nicer in the evening than it does during the day. And these are my contact details if anyone should want to contact me with regards to a question that may have emerged during this presentation. Let me see if this works. Yeah, so I have no conflicts of interest to declare. I have no interest with any of the companies and the drugs that they produce that I will mention during this talk. And when I started conceptualizing the talk, I was thinking about obviously I do have a conflict of interest. I was a fellow in Toronto, and many of the ideas I have are probably related to the things that have been taught to me during those 2 years that I spent at the Peterman Cardiac Center doing adult congenital heart disease. But one of my first memories of Toronto is actually that it was very, very cold, and these are some of the images that we took weeks or months after we arrived. But back to the lecture. So the aims of the lecture are to describe Fontan physiology at rest and during exercise, because if we want to talk about pulmonary vasodilators, I think we have to know how a Fontan works. Second, I will touch upon the fact, do we actually have evidence for using these drugs in patients with a Fontan circulation? And if we did some studies, what are the acute and the chronic effects of pulmonary vasodilators in Fontan patients? Because as always in patients with a Fontan circulation, things are not that easy. I'll provide some insights in how I approach my patients to make sure that exercise limitation in my patients is related to pulmonary vascular disease and not to any other issue that may be present in that particular patient. Fontan palliation, we know that, is palliation for patients with a single anatomical or functional ventricle that cannot go towards biventricular repair. Some of the pathologies initially develop a patient with tricuspid atresia, but now we also do that for pulmonary atresia with intact ventricular septum, unbalanced AVSDs with either left or right dominance, double inlet left ventricles, and patients with hypoplastic left heart syndrome. The people joining this presentation also know that there's been a lot of changes to the Fontan palliation, going from the initial report from Fontan, François Fontan and Baudet in 1971, where you see that there is an end-to-side connection between the superior caval vein and the right pulmonary artery, the so-called classic Glen, and then the right atrial appendage that is connected to the left pulmonary artery, actually with an aortic homograft in place, ligation of the main pulmonary artery, closure of the ASD, and even a valve here at the connection between the IVC and the right atrium. This is not how we do it nowadays. Nowadays, a Fontan looks like this, where you have the SVC connected to the pulmonary artery, and then the IVC using a cortex conduit, usually 20 to 22 millimeters, also connected to the pulmonary artery. Either the main pulmonary artery is ligated, or there is a DKS in place. But this is usually how the Fontan connection looks in patients we see nowadays. If you look at the long term, because that's what we're going to talk about today, we'll find some reports, and this is excellent data from the New Zealand and Australian registry looking at all their Fontans, saying that up to 25 years after Fontan completion, actually survival is not that bad. So this is more than 1,000 patients. This is both atrial pulmonary connections, lateral tunnel patients, extracardiac conduits, just a few hypoplasts included in the registry, but still if you look at survival 15, 20, 25 years after Fontan completion, it is 93%, 90%, 83%. So I think the pediatric cardiologists and the congenital cardiac surgeons are doing this in the evening saying, well, we did a pretty good job. The thing is, when data from the adult clinic come, they look surprised because this is data from the Brompton. And if you look at the 5-year risk of death for a 40-year-old Fontan, it's actually the worst of all pathologies that we do have. So probably there is an issue with the Fontan circulation. So we know that our patients with a Fontan circulation, there is attrition of the circulation and so-called Fontan circulatory failure, but also long-term comorbidities are frequent. I think everyone recognizes this graph from my colleague here in Leuven, indicating how a Fontan system works, where now the pulmonary circulation, systemic circulation are connected in series, but at the expense of higher systemic venous pressure and low cardiac output. And a second thing is, after many discussions with Mark, you can also see that there's changes over time where venous pressure continues to increase, probably due to increased pulmonary vascular resistance, but also that there's an increase in wedge and left atrial pressure and diastolic pressure due to stiffening of the systemic ventricle. Obviously, this is also not the same for every patient, and I think if you look along the life trajectory of our Fontan patients, some will have a more complex anatomy and will be worse off from the get-go and have a more difficult life trajectory. Some of our patients are obese, do little sports, and hence compromising their long-term outcome. Sometimes maybe also socioeconomic status is important for long-term outcome, but it's not just pulmonary vascular resistance. We also have to look at the ventricle, at the atrioventricular valves. There may be rhythm issues, thromboembolic risk. There will be liver disease. There will be renal dysfunction. So attrition of the Fontan and Fontan circulatory failure is a very big umbrella covering a lot of topics, and we need to make sure that we're talking about the same thing. If I see Fontan patients in clinic, sometimes or quite often they report exercise intolerance. And if you look across the ACHD spectrum, and this is data from the Euro Heart survey way back, you can see that exercise tolerance is reduced in all CHD subgroups, and is more reduced in those with more complex anatomy, especially those with a Fontan circulation, where you can see that more than half of the patients actually symptomatic in contrast to other subgroups. This is other data just looking at peak oxygen consumption, and again you can see that the Fontan cohort is not the best of our patient population with a reduced peak oxygen consumption when compared to other subgroups. And Mike Katsoulis and Gerhard Diller did excellent research on this topic, reporting exercise tolerance, reporting values for peak oxygen consumption in patients with a Fontan circulation. And this is the histogram you get when you put all those Fontan patients on a bike, or if you perform a cardiopulmonary exercise test. You see that if you would assess this according to normal values, you'd see that a lot of our Fontan patients would have mild, moderate, and even severely impaired exercise capacity. Probably it says something about the normal values being different for our Fontan patient, and also says something when we evaluate our Fontan patient that we need to look at normal values, or the values we would expect for a Fontan patient of a certain age. Also interesting is that there's not a significant difference between the different types of Fontan that we assess. Again, when you evaluate exercise intolerance, which is probably frequent in our patients, we also need to realize that it's not just cardiac issues that cause exercise intolerance in our patients, especially Fontan patients, that there may be pulmonary problems as well, there may be skeletal muscle dysfunction, there may be desaturation, anemia, deconditioning, and all kinds of other things that may be going on in our patients. And I think it's important to know exactly what is going on, because if we make an incorrect diagnosis, either we start no treatment or we start inappropriate treatment, which could or may affect prognosis and will lead to frustration both among us as physicians, but also with the patients if they feel that they're not treated well. So let's focus a little bit on the physiology of the Fontan circulation, and these are some of the, I don't know, maybe more difficult slides, but just bear with me, and if there's any questions, I'd be happy to take them at the end. So this is again the graph from Mark Gewillig, where he indicates that now you actually have the pulmonary and the systemic circulation that are connected in series, and he likes to refer to this connection of starting from the caval vein over the pulmonary arteries to the left atrium as a Fontan portal system, which is now the critical bottleneck of the circulation and the main cause from all the issues that we see on the long run with our Fontan patients that all relate to high venous pressure and low cardiac output, such as Fontan-associated liver disease, PLE, low exercise capacity, renal dysfunction, and so on. The thing is, if we dig a little bit deeper, it's interesting that venous return is very important in our Fontan patient, because we usually pay little attention to venous return in our patient with a biventricular circulation, because it's maybe abundant and it's maybe there's little things that affect it. But if in Fontan patient, it is important because we need that to get blood through the pulmonary vasculature. And it's been estimated that we need about 15 millimeters mercury to keep the pulmonary vasculature patent. And this is more or less what we get in our so-called good Fontan patients. And if they are at rest or do some exercise, it's mainly passive and weakly active forces such as peripheral muscle contraction, respiration, and suction due to downward displacement of the atrioventricular valve that is important to keep venous return going, to keep preload to the ventricle intact, and to keep cardiac output intact. This is a very good article by Ben Leuven that was published now 10 years ago, where they looked at the determinants of total stroke volume in patients with a Fontan circulation and compared that to controls where they evaluated at rest, unloaded exercise, and then did some interventions, and they were able to dissect that it's probably mainly the muscle pump that contributes most to stroke volume, especially stroke volume increases during exercise in patients with a Fontan circulation. If we say that venous return is important, it's important to look at where it comes from. We see that it comes from the SVC, about 30%, from the IVC, 45%, but also from the hepatic veins, about 25%, which are now portal vessels to the lung. Maybe it's not easy to understand, but you have two capillary beds which are now connected in series without a pump in between. And since venous return is important, it may also be of interest to look at the venous return curve that we know from Guyton, for those who remember their physiology textbooks. And this is the normal venous return curve. This is the mean circulatory filling pressure when there is no cardiac output. And there's an interesting article that was published already more than 20 years ago in the American Journal of Physiology and Circulatory Physiology, which indicates that in Fontan patients, there's actually a counterclockwise rotation of this venous return curve. And if you would leave it like that, you would actually see that venous return is not matched for the cardiac output that is needed. So there is an adaptation in the Fontan patient with an increase in blood volume, which in order to keep venous return stable, but at the expense, obviously, as we all know, of increased systemic venous pressure. Here you see the Frank-Starling curve as well, which I indicated as being slightly depressed, which is probably true in most of our patients, but not necessarily for all. But this graph, I think, is important because it it indicates that factors that determine venous return in our Fontan patients actually determine filling of the systemic ventricle and hence cardiac output. Interesting in their article is also that they indicate that there is a shift of venous resistance, which is usually only a small part of total vascular resistance, towards pulmonary vascular resistance, which is now included in venous resistance. And to me, this is why the pulmonary vasculature is actually indeed the critical bottleneck in patients with a Fontan circulation and cannot be neglected because it overtakes venous return, it determines venous return, hence preload, hence cardiac output of the patient with a Fontan circulation, and obviously factors affecting mean filling pressure such as blood volume, venous muscle tone, atrial pressure, venous resistance will affect venous return, preload, and cardiac output of patients with a Fontan circulation. This was some physiology at rest. I think exercise is even more interesting and maybe a little bit more practical, because we know when we put Fontan patients on a bike, they have limited exercise capacity. But where does it come from, or is there cardiac limitation? And this is some data of experiments we perform. We put good Fontan patients in an exercise cardiac MRI, and we calculated end diastolic and systolic volume, stroke volumes, cardiac output. And we matched that with some healthy controls. And as you can see, even our best Fontan patients actually are limited in the extent that they can augment cardiac index and also limited in the amount of watts that they can produce. And if we further dissect this and look where this comes from, we see actually that in this group of Fontan patients, heart rate actually increased quite well. I know that chronotropic incompetence is frequent in Fontan patients and may be a concern for exercise limitation as well, but I'll come back to that later. But in these patients, at least, that was good. You see that there is a drop in stroke volume, which is interesting because if you look at this, these were good Fontans, and already at 100 watts, there's a decrease in stroke volume, which corresponds with a decrease in end diastolic volume index, indicating some degree of preload limitation. But not solely that, there's also no decrease in end systolic volume index, so probably also some kind of reduction in contractile reserve in our Fontan patients. Again, to put it a little bit more conceptual, and this is based on work that André Legerge did in athletes. He always told me that exercise is work of the right ventricle, not necessarily of the left ventricle. And I'll just guide you through the graph. Here you see the increase in hydraulic power relative to baseline. And this is a systemic ventricle, and this is the subpulmonary ventricle. But in a biventricular circulation, you can see that the increase in hydraulic power of the subpulmonary ventricle is steeper when compared to the systemic ventricle, indicating that exercise is actually RV work. Well, that's obviously, if we're talking about Fontan patients, that's an issue because they don't have a subpulmonary pump, and all that subpulmonary work is provided by passive forces and weakly active forces. That means that in some way they are limited in the extent that they can increase the hydraulic power relative to baseline, as you can see here. So in the green dotted line, you see a good Fontan. Again, steeper increase for the subpulmonary work, but limited because obviously they don't have a pump. And if you then go to a worse Fontan patient with increased pulmonary vascular resistance, with higher wedge pressures, well, this increase will be steeper, limitation will be earlier, and the peak cardiac output will even be lower. Do we have some evidence for that? Yes. This is, if we look at Fontan pressure or PA pressures during exercise, this is a good Fontan. This is a New York Heart Association Class 2 Fontan and a bad Fontan. You see that resting pressures actually go up slightly. Your resting cardiac output may decrease slightly, but especially during exercise, you see those changes where you see a steeper increase in PA pressures relative to cardiac output. The slope of the pressure relative to cardiac output becomes steeper, and the pressures rise higher as Fontan as worse. The problem is, and you could say this is all increased pulmonary vascular resistance in patients with worsening Fontan circulatory failure, but we also observed, and I'll get back to some real-world data is that the wedge pressure actually slightly increases when our Fontans become worse, and also the wedge pressure increase. The increase in wedge pressure during exercise becomes steeper in a subgroup of Fontan patients that we see in our clinic. So we cannot just attribute this solely to increased pulmonary vascular resistance. Some patients, it will also be increased wedge pressures that drive this increase in Fontan pressures during exercise. And this is a great article that you should read from the Mayo Clinic by Alexander Ekpe and Barry Borlow, where they evaluated symptomatic Fontan pressures and with invasive catheterization and assessed the change in PA pressure or Fontan pressure from rest to peak exercise, and also the change in cardiac output. And they were able to define that those with a slope of more than 3 millimeters mercury per liter per minute actually did worse, and that was associated with endothelial dysfunction, liver stiffness, renal dysfunction, volume overload, and higher exercise intolerance. The only thing was that they in this article suggested that this may probably be due to increased pulmonary vascular resistance. But when we were invited here in Leuven to write an editorial, and I just plotted their data, which is symptomatic Fontan with low TPR, symptomatic Fontan high TPR, with our data that we obtained a few years back, you see similar results. You see a drop in stroke volume index during exercise, which is all pretty similar. But what was very interesting to me is that the increase in wedge pressure relative to cardiac output, even in their patients, was actually quite steep, and definitely steeper than what you would expect in a normal control. And second, although the peak heart rate was definitely lower than you would expect, the steepness or the rise in heart rate relative to cardiac output was steeper than you would expect in a normal person, challenging a bit the notion of chronotropic incompetence in these patients. It was interesting because just now, and again an excellent article from the Mayo Clinic, is that they actually took these comments and evaluated the wedge pressure increase during exercise and relative to cardiac output in normal controls, and compared it to a HFpEF population. And although pressures at rest are quite low in Fontan patients, when you exercise them, they go up quite frequently and actually almost reach those pressures of HFpEF patients. And if you look at the steepness of the increase, it's very similar to a HFpEF population. So I think we need to take that into account when we assess our patients before we say that anything is related to increases in pulmonary vascular resistance. So just maybe summarizing what I've gone through so far and having a look at the time, okay? So I think the absence of a subpulmonary pump changes physiology of our circulation, both at rest and during exercise. And we have high systemic venous pressures and low cardiac output, which are a hallmark of Fontan physiology and probably the main reason for all troubles we see down the line. And obviously this limits exercise capacity. I think looking at venous return and hence cardiac output is important and is determined largely by pulmonary vascular resistance if all else is fine. But there is attrition of the cardiovascular system due to these changes, and I'd like to refer that as accelerated aging of the ventricle, of pulmonary vasculature, but also we need to look at valves, rhythm connections, as these will impact the efficiency of the Fontan circulation. So I think it makes sense to consider the pulmonary vasculature a target for intervention, but we should not lose sight of the valve, the ventricle, rhythm connections, and everything else. So we should tread carefully. So I'll move on to the second part of my talk, which is, do we have in the literature any arguments in favor of pulmonary vasodilators? We're lucky because in the field of pulmonary arterial hypertension, they have therapy that addresses the three pathways, the endothelin pathway, nitric oxide pathway, and prostacyclin pathway, which have shown to improve patients with pulmonary arterial hypertension, even improve prognosis of these patients. And if I say, well, the pulmonary circulation is the critical bottleneck of our patients, it makes sense to address this and to try to lower pulmonary vascular resistance to improve our patients. There's not much data that goes, there's not much basic science, I would say, in patients with the Fontan circulation, which makes sense because it's a small group, it's a small patient cohort, it's not that easy to obtain, but I do have some interesting studies that I want to share with you. First of all, I looked if there's any morphological or molecular changes in the pulmonary vasculature, and this is a study from, again, 20 years ago, where they took a lung biopsy at the time of Fontan completion. And then they compared, and this is the black bar versus the white bar, those who failed, black, and those who didn't. And they looked at the distal alveolar duct arteries. And what did they observe? Well, in those who failed, they had definitely thicker, a higher wall thickness, and they saw some extension of muscle into the distal arteries. Moreover, there were some arguments for endothelial dysfunction with high enos expression and endothelin 1 expression. So this kind of supports the possibility of using pulmonary vasodilators in Fontan patients. This is a Japanese study, another study where they took autopsy samples of patients who died after the Fontan procedure, and that was around 12 years of age. And then they distinguished those who died from Fontan failure to those who died predominantly from what I interpreted as pump failure of a Fontan versus those who had sudden deaths or died due to an infection versus normal controls. And again, you see increased wall thickness. That is definitely true, especially in those with Fontan failure. And if they looked under the microscope at the pulmonary blood vessels, they saw intimal and medial hypertrophy and proliferation of smooth muscle cells, again indicating that this may be a good target to address with pulmonary vasodilator therapy. However, it's not all evidence points in the same direction. And I very much like this study from the Netherlands, published a couple of years ago in the Journal of Heart and Lung Transplantation. Again, taking autopsy samples of patients who died after the Fontan procedure, but they divided in those who died early, within 15 days, or late, more than 5 years after Fontan completion. And indeed, in those who died early, they saw this increased thickness, which was mainly due to muscularized media. So the thing we saw in the last few slides. But in those who died late after Fontan completion, they indeed saw increased wall thickness, but this was not due to medial hypertrophy and more smooth muscle cells, but they observed eccentric intimal fibrosis and actually a loss of vascular smooth muscle cells in the medial layer, a thing that is more frequently associated with aging and also with thrombus formation and non-pulsatile flow. And these changes are not the changes that are probably affected by pulmonary vasodilator therapy. So a word of caution here, that not everything points in the same direction. Is there a clinical correlate that PVR may be increased in patients with a Fontan circulation? There is, and this is actually a nice study where they observed an increase in transpulmonary gradient and pulmonary vascular resistance with all caveats post-transplant if patients had a Fontan palliation more than 1 year ago. So here you see the patients that were transplanted late after Fontan palliation. You can see that pre-transplantation transpulmonary gradient was actually reasonable, but immediately post-transplantation increased significantly, as did pulmonary vascular resistance. Word of caution again, because late outcome was not determined by this increase in pulmonary vascular resistance, nor was it determined by RV failure that would have been caused by this increase in pulmonary vascular resistance. So we know physiology. We know that the pulmonary circulation is at the center of the Fontan circulation, so it makes sense to continue investigating this. If you look at preclinical work, we know that it is extremely limited in Fontan patients. And there is some evidence that pathology looks similar to PAH, especially prior to and early after Fontan palliation. But we need to consider that pathology may look very different from the pulmonary vascular remodeling that we see in PAH late after Fontan palliation. And molecular changes show some similarities, which appear to be more pronounced in Fontan failure. And clinically, and I think everyone would agree, the degree of pulmonary vascular changes are difficult to assess given low flow in Fontan patients, issues to measure pulmonary blood flow in Fontan patients, and so on and so on. Still, again with a word of caution, I think it makes sense to study pulmonary vasodilators in Fontan patients. And we did study it. It's interesting to see in the past 15 to 20 years, we did a lot of studies, and I apologize if I haven't included all studies, but we did look at the effect of pulmonary vasodilators in Fontan patients. One of the first studies that was published in European Heart Journal now almost 15 years ago was by Alessandro Giardini, where he evaluated peak oxygen consumption before and just after the intake of sildenafil in a group of 18 patients, and where he saw that in those who took sildenafil, there was actually a significant increase in peak oxygen consumption, whereas there was no change in those who didn't take sildenafil. Important, he described his group quite well. AFib in 28%, more than moderate or more ventricular dysfunction in almost three quarters of patients, a lot of AV valve regurgitation, a lot of diuretics, and relatively high New York Heart Association class. It makes me wonder a little bit that these patients may have not just increased pulmonary vascular resistance, but that AV valve regurgitation was an issue, that systolic dysfunction was an issue. We have no information on end diastolic pressure, on wedge pressures, and so on. Because you have to realize that if you give sildenafil and the reason of your increased total pulmonary resistance is post-capillary, you may actually do more harm than good in these patients. We did study that as well, as I indicated before. We put good Fontan patients, so no heart failure patients, under we performed exercise cardiac MRI. We measured volumes, we measured pressures at rest and during exercise, before and after an oral dose of sildenafil 50 milligrams. And we were able to show that actually cardiac output, both at rest, but especially during exercise, increased with about 12% in this acute experiment. Interesting was that cyclic GMP before sildenafil administration didn't change, and it did increase after the intake of oral sildenafil. Am I absolutely sure that this is just because of a decrease in PVR? Not absolutely. We don't have wedge pressures, and blood pressure, systemic vascular resistance decreased as well. But a hint towards an effect. Other studies evaluating sildenafil. This is a study from Dr. Kohlberg and Reitschik in 28 patients evaluating sildenafil for a period of 6 weeks, and was negative on the primary endpoint. But again, a group of good Fontan patients, relative acute experiment, not so long. This is a different approach where you pre-select patients that actually may have a better indication. In this study group, 28 patients with an indexed pulmonary vascular resistance of more than 2.5 Wood units times square meter, where they provided sildenafil for 12 weeks, actually saw a decrease in transpulmonary gradient and pulmonary vascular resistance indexed. What I miss a little bit in this study, that despite more than half of the patient was on diuretics, which I think is important, little is mentioned on ventricular dysfunction, either systolic or potential diastolic dysfunction in this patient. And I think the reason why I put this here is because I think this is crucial when doing those experiments in patients with a Fontan circulation. Some other studies evaluating not sildenafil but bosentan, where they saw an increase in peak oxygen consumption in the intervention group. It was a larger study, 75 patients for a period of 14 weeks. But again, no information on the type of patient that was actually included in the study, except that they didn't have heart failure. But we know that that is difficult to define in Fontan patients. Again, another study by an Italian group, pre-selecting patients with a higher PVRI, a bit difficult to understand, but they had a bosentan group, they had a macitentan group, again, small numbers, but with a hint towards improvement, especially in pulmonary blood flows in the patients who took bosentan and macitentan. So I think I have no time to present all small studies, but there's been a lot of small, acute, short-term, single-center studies hinting towards benefit, some of them neutral. And I think the community did a tremendous job actually putting together larger randomized controlled trials for our Fontan patient. And I cannot stress enough how important that is for our community to have those trials and not to stay with the smaller studies and then leave it up to the clinician trying to decide with incomplete data. So this is the FUEL study, very large study in Fontan patients assessing a compound that is similar to sildenafil for 25 weeks. Not much information on the type of patients that was included, but again, no heart failure patient. And I think in summary, it didn't reach its primary endpoint, so it was negative for the primary endpoint, which was an increase in peak oxygen consumption, so it failed to reach its primary endpoint. But in a subgroup analysis, there were some interesting signals towards improvement at anaerobic threshold, and so during submaximal exercise. A second study, and there is a RUBATO trial which evaluates macitentan, again in a quite large group of Fontan patients. I apologize, I couldn't find the actual article. Maybe it hasn't been published yet. I think so. But if you go to clinicaltrials.gov, you see again that it didn't reach its primary endpoint. So both for a PDA5 inhibitor and both for an endothelin receptor blocker were negative for their primary endpoint. So a bit disappointing for our patients. So what did the studies show so far? So although we have some acute and short-term studies, often single centers that hint towards a benefit, larger, well-performed studies were negative for the primary endpoint. There were some interesting signals in submaximal exercise for sildenafil, which corresponds more to daily activities, which may be more relevant for Fontan patients. But to me, that indicates that pulmonary vasodilators in a broad, unfiltered Fontan population has little effect, although maybe for selected patients, it may still have benefit. And then it begs the question, so how do we define this? And this is the last part, and I apologize if it is taken a little too long. This is how I approach my patients nowadays. So let's start with some case examples, and apologies, some of you probably seen these case examples before. So this is a gentleman, right atrial isomerism with a TAPVC, unbalanced AVSD with right dominance, transposed great arteries, PS, and a single coronary artery. He underwent TCPC, also a repair of his tricuspid valve and an epicardial pacemaker in 2005. And here you see the Fontan conduit, which was stented. Probably this is not correct. It's probably a few years later, but I probably copy-pasted this. He presented with sustained VT and collapse in 2018 and was treated with a defibrillator, neurologically intact. Developed atrial fibrillation in 2020, for which he was anticoagulated. And his blood pressure is on the low side, a regular heart rate. Here is his ECG, and his resting stat is 91%. He reports, there's very little I can do. I mostly sit in the sofa. I used to help out at the farm of my parents, but that is important. That is not possible now. And you put them you perform a CP study and have a peak oxygen consumption of 12.7 or 28% predicted. He also presented with ischemic colitis, which was thought to be due to low flow, and he now comes to me asking what are my treatment options. This is his echo, reasonable function, but at least moderate AV valve regurgitation. Second patient, an older lady, 39 years old, tricuspid atresia, VSD, a persistent left SVC, 2 coronary sinus, 2 right atrium, had a BTT shunt in 87, a classic Fontan in 90, was converted because of a lot of atrial arrhythmias in 99, reduction of the right atrium, epicardial leads, and again developed the past few years more arrhythmias, comes to clinic, reasonable blood pressure. This is the ECG and the heart rate, and a resting set at 83%. Also says there's very little I can do. Doctor, you perform a CP study, 9.8 or 44% predicted for the age of the patient. Again, what limits her exercise capacity and what should we do for this patient? And the last patient is a younger lady, tricuspid atresia VSD, similar to the previous patient, VTT shunt, TCPC, and a stent in the left pulmonary artery due to hypoplasia, and in the conduit in 2020. She had complications. She developed a pulmonary vein stenosis on the left side. She is in New York Heart Association class 1 to 2, doing reasonably well with reasonable blood pressure, heart rate, and saturations. And she, on the CP study, does reasonably well. And she has a pregnancy wish and comes for risk stratification. As I already told you, when Fontan patients come with exercise intolerance, it's usually multifactorial, and this has been nicely summarized in this paper that was published just this year in the Canadian Journal of Cardiology, and it's a definite must read. But I think we can do CPET study for certain reasons. We can go for invasive CPET with a cardiac catheterization, as the colleagues at Mayo Clinic do, which gives us a more in-depth comprehension of pathophysiology, but is very invasive, difficult to organize, and associated with high costs. So what I will suggest is that CPET echo in these patients is the ideal gatekeeper for more invasive studies. And I'll just guide you through how I perform these studies. This is just referring to a consensus paper. I don't think it's really all that important, just the setup of our patients where we have the echo machine, where we have an ECG, and where we have the CP study all at the same time. So trying to have as comprehensive information as possible. This is not a Fontan patient. We usually also have a peripheral venous line for peripheral venous pressures, which are similar to Fontan pressure, but I'll come back to that later. So that is the setup that we have in our laboratory and how we exercise our patients. And this is how we go through it. So there's exercise intolerance, and we perform our CPET echo. First of all, we look, was this the test maximal? Obviously, there's reasons why some patients would perform a submaximal test, orthopedic reason, anxiety, functional reason, etc., etc. But it's important to assess whether the test was maximal or not. You look at reference values for Fontan patients, and these are from the Brompton, I think is excellent. And then you can see that how our different patients, male and female patients, where they are located within this spectrum of Fontan patients, and if peak oxygen consumption is lower than expected. If it is lower, we continue, and we assess pulmonary limitation by looking at ventilation and the maximal voluntary ventilation, which can be estimated from an FEV1 that is measured just before the test. Pulmonary limitation in some patients that have severe scoliosis can be present in our patient and is important to assess. Just knowing this already gives you some prognostic information, because if some patients are in the lowest quartile of peak oxygen consumption, their prognosis is worse when compared to patients who have a higher peak oxygen consumption. So you already have that information. I refer to the peripheral venous pressure measurement, and there's been excellent work by Krusch and Veldman, and also confirmed by the colleagues in UCLA, where central venous pressure and peripheral venous pressure, just pressure measured on a peripheral venous line, actually corresponds quite well, and that it changes during exercise. So it's something you can easily measure, is not too invasive, and can be implemented in clinical practice. So you assess Fontan pressures, and at the same time, using your echo, you assess cardiac output. VTIs, LVOTs, heart rate is easy to measure even during echocardiography, and you can construct these pressure flow plots that I've shown you before, and also say something about prognosis of the patients. similar to other pathologies, having a total pulmonary resistance more than 3 millimeters mercury per liter per minute is indicative of a worse prognosis when compared to those who have a lower slope. This is how we do it. This is the first patient. His moderate AV valve regurgitation increased into severe AV valve regurgitation during exercise. His Fontan pressure that was actually low or good at rest increased quite quickly at only, I think this was 40 watts. And here you can see his stroke volume didn't change, as did his heart rate, not so much. And his cardiac output remained low throughout exercise. So probably in this patient, valvular regurgitation, a limited increase in heart rate, and a limited systolic contractile reserve actually contributed to the complaints of this patient, but not pulmonary vascular disease. His slope is significantly elevated. His prognosis is bad. We put him on the transplant list, and he was actually transplanted 2 weeks ago. He's doing quite well. I'm quite happy about that, and especially obviously for the patient. We know from large data sets that AV valve regurgitation is important. In fact, probably an important contributor to worse prognosis in Fontan patients, especially if you have a systemic right ventricle, as this patient in fact had. Remember our second patient, the older lady who had a TCPC post-conversion. We did the same thing. She only went up to 60 watts. As you can see here, pump function is actually not that bad, actually it goes up during exercise. There is no significant AV valve regurgitation during exercise. Here you can see a real-world example of the VTIs, which are feasible, but sometimes not as easy to collect. And there was quite a bit of respiratory variation in this patient, so we took an average of those measurements. And these are the pressures that you can get whilst performing exercise in our Fontan patient. So she started out at 20, and then she increased quite quickly to just above 30 millimeters mercury. You can calculate stroke volumes, which dropped at peak exercise, as did cardiac output, which was probably the reason why she had to stop. She underwent a full catheterization. Her wedge was 22 millimeters mercury, transpulmonary gradient only 2 to 4 millimeters mercury. So most likely, the reason for her exercise intolerance is diastolic dysfunction in this patient. There was preload limitation caused by this diastolic dysfunction, and she was also desaturated rest, which further increased during exercise. So those 3 causes of exercise intolerance. She's also considered for transplantation now. However, she also has worsening renal function, so probably she'll be put on the heart plus kidney transplant list. I'll just continue, but again indicating that diastolic dysfunction, if wedge pressure and diastolic pressure is elevated in Fontan patient, those patients have worse prognosis. Our last patient is our young female patients asking for pregnancy. We did the same thing. She actually performed quite well, 80 watts. Her systolic function increases during exercise, no significant AV valve regurgitation. You see that heart rate increases nicely. Cardiac outputs probably also increases. She also reaches around 30 millimeters mercury at peak exercise. This is the summary of her findings. But probably her slope was also elevated. And the reason in this patient was pulmonary vascular disease. But what kind of pulmonary vascular disease? This is a cardiac catheterization where you can see hypoplasia to the left lung, very poor flow in the left lung. This was the patient with pulmonary vein stenosis. So I think it's important that if you consider the pulmonary vasculature as a determinant of exercise intolerance and maybe also prognosis in our patients, that it's not always pulmonary vascular resistance at the level of the small pulmonary blood vessels, but we need to consider pulmonary hypoplasia, especially in the left PA, pulmonary stenosis, distortion, thrombosis, etc., as potential causes of exercise intolerance. And obviously, treating this patient with a pulmonary vasodilator will likely not have the same effect. We actually did, which didn't change much, and we weaned her back off of the pulmonary vasodilators prior to pregnancy. This is a final slide where Ethan Kung, who I forgot where he works now, but he was with Dr. Marsden in San Diego before, where he modeled actually the impact of different problems in the Fontan circulation. Is actually the effect of an abnormal PVR on cardiac output and PA pressures is a lot less than the effect of AV valve regurgitation in a Fontan patient. It's not just pulmonary vascular resistance. This is a summary of my assessment of Fontan patients in clinic and trying to determine the reason for exercise intolerance and trying to get them the best possible treatment. So, to conclude, a normal pulmonary vasculature is crucial for a good Fontan circulation because it's at the center of the Fontan circulation. It's a critical bottleneck. I think the responsibility of the pediatric cardiologist and the congenital cardiac surgeon is huge, just to make the Fontan as good as possible, because once it is rolling, it's very difficult to change track. There is accelerated aging, both of the pulmonary vasculature due to lack of pulsatility, but also of the ventricle due to the same reason. We should be aware of pulmonary vascular disease, especially when going for heart transplant, because we don't want RV failure in the post-transplant setting. In unfiltered patient cohorts, results of well-designed RCTs are disappointing. There are some signals, but I think this is mainly due to the fact that Fontan circulatory failure has multiple etiology. And it probably is important to better define this, especially since inappropriate treatment is not necessarily harmless. I'll finish up with some last pictures of my kids, remembering the good time that is approaching the end of October, where we celebrated Halloween. I must say, Halloween in Canada is a complete different level when compared to Belgium. I'll be happy to take any questions, Rafa. Thank you.
So thank you, Alex, for an excellent, as always, talk and very comprehensive. And there's some questions. So Isabel Bondermal from Edmonton has some questions. So Isabel, just unmute your microphone and please ask your questions.
Hi, can you hear me?
Absolutely.
Yes, we can hear you.
Thank you so much. That was an awesome talk. I love your approach, trying to break down what is causing the Fontan failure. My question is, in your setup for doing simultaneous CPAP and stress echo, when I was looking at those cases, it occurred to me that if you hadn't done them simultaneously, you still could have got that information. So can you comment on that? Like, is it, because we can do CPAP, we can do stress echo, and I thought the venous pressure was really useful, but do you need to do them all together?
It's a good question. I think it depends on the setup you have in the hospital, and it's all about logistics, right? For us here, I think adding echo into the mix is not really that difficult. So usually our patients are followed with regular CP studies over the years. And sometimes if I just want to be a little bit more comprehensive, we have a dedicated morning or a couple of mornings that are dedicated to CPAP echo, where we perform 3 or 4 of those tests in a morning. And I'd like to have those measurements at the same time, because to me, it really, it's like instantaneous feedback. So there's someone recording the pressures, there's someone I'm doing the echo, there's someone at the CPAP machine, and so I know exactly what I'm measuring at what time I'm measuring it. So I guess you could do it separately. I don't think it's that difficult to combine it if you know exercise, if you do exercise echoes and CPAP and CP studies, and it gives you a little bit more confidence that the things you're seeing occur actually at that particular time. But it depends. It depends. It depends on the setup in the hospital. I know that it's sometimes difficult to change something.
Thank you.
So Lorna said in the talk that I really like your mechanistic approach to symptomatic or deterioration rather than one size fits all, and that's from Lorna's home. So I'm aware of the time, but I have a couple of questions. So there's one thing that always, that this is a topic that I really love, and I really love the way you approach this. But there's something that always I wonder why this happened. Many of the studies that we have with pulmonary vasodilators acutely, so the one that you use from Giardini, or even your studies with MRI exercise, seems that if you give Fontan patients without knowing the mechanism and you give vasodilators acutely, many of the studies said that you have an effect. You just give the pulmonary vasodilator, you just do the exercise test in that patient right now, and works. When we do it to extended population, as the two trials that you have shown, and the RUBATO paper is not out yet. It's been presented in a conference, but it's not out yet. But it was disappointed. A majority of them are negative, apart from the Tempo trial that had a little bit of positive, and we can discuss that was just 1 millimeter of mercury of improvement in the 1 millimeter per kilo per minute of improvement in peak VO2. Majority of them are negative, but acutely many of them are positive. Would you think that can be the reason for that?
I have no. That's an excellent question, Raf. I have no idea. I think some of the acute effects are maybe not necessarily due to pulmonary vasodilation, but maybe effect on blood pressure. That's what going back to my study, that's probably what I would try to dissect a little bit more if I redid the study. So because if I give sildenafil, the blood pressure is actually decreased, and maybe the combination of pulmonary vasodilation with decrease in afterload to the ventricle is actually the effect that I observed. There's this interesting Japanese study where they gave everything at the same time, and they say, well, we're actually able to improve hemodynamics. I'm not sure if you have to give nitrates and sildenafil at the same time, if that is a good idea, but still, they were able to show that. In terms of the chronic studies, I think these are the best studies. I think these are the ones that we have to rely on, because it's amazing that we have those studies, and we need to trust the results that they provided. There's two issues, I think. One, I'll have to look into the patient cohort of RUBATO, but I think they mainly included non-sick patients. So not the ones with Fontan circulatory failure. The ones with Fontan circulatory failure obviously have many issues: valve issues, ventricular issues, rhythm issues, and stuff like that. If you include healthy Fontan patients, what do you expect after 16 weeks, 52 weeks? I don't know. In the data from the Netherlands, it's intriguing to me that there is accelerated aging of the pulmonary vasculature. Hypothetically, if you continue giving those vasodilators for, let's say, 10 years, you may see an effect, but we'll never have those trials.
Go. Sorry, Alex.
No. So we don't have those trials. And second, it's probably in the older patients, you need to select them. And that's what I try to do with a more comprehensive assessment. So if you start young, probably you need to treat a long time, which we're never going to do. And if you start late, you need to select the right one. Very simplistically said.
No, but I think I totally agree with you. I think what happened is that we are. I think what your work proves is that not every Fontan is the same, and not every Fontan fails equally. And we have, as you did, that's my way of thinking as well. So you have two groups of Fontan, those that are okay. And the question to those is, if we give pulmonary vasodilators early on, are we going to change the trajectory of the disease, which we don't have the answer, and that some of these patients are included. Second question is, in those that are failing, you need to learn. But I don't think this is a question. I think you guys, with your work, have proven this, and with the work of the Mayo Clinic, if your Fontan is failing, you need to understand why it's failing and what is the mechanism to decide how to treat that patient. And pulmonary vasodilators is not a solution for every failing Fontan. For some might, and probably little than we felt or we thought, but definitely you need to understand the mechanism of failure. So I just thank you for the work that you do in this, because it's amazing, and thank you for the excellent talk. I think I would have million other questions, but it's just 9:05, so I don't want to ask more questions. But I really want to congratulate you for an excellent talk, and again, thank you for an excellent job in a topic that I love. So, and to all of you that joined us today, so thank you for joining us, and see you here in 2 weeks. So, and good night or good morning or good evening, wherever you are in the world. So, Alex, have a good day, and thank you again for joining us.
Bye, Rafa. Thank you for having me. Bye-bye.